Hi, students. This is a recorded lecture. I will be covering chapters 15 and 16. Chapter 17 deals with disease outbreak, which we've already covered that in previous lectures. And then I will cover also chapters 18 and 19. So when we're dealing with case management, typically our clients are faced with challenges every day in order to seek care that they actually needed once they're sick. So case management helps the client actually transition to home. So certain things they may help with setting up home health, setting up physical therapy, helping them actually get medications, transportation to and from the physician's office. Now, typically your case management is usually in the hospital where they also have a social worker that also aids in helping the client get what they need when they're transitioning to home. The Affordable Care Act endorses the use of integrated systems to emphasize population health management across the continuum rather than on episodes of illness for an individual. There's also been a shift from inpatient care as a point of management to primary care providers as a point of entry. Typically, our clients used to come in to the ER because they ran out of blood pressure medication. So, with the Affordable Care Act, it has kind of taken that barrier away to where it's very important that the clients actually follow up with their primary care physician versus seeking out the ER as their primary care. The Affordable Care Act also provide care management services and programs that provide access and accountability for the continuum of health. And then also the Affordable Care Act um, measures out the system's outcome. So depending upon the quality of care that that organization actually provides to the client will basically determine their reimbursement through CMS, which is the Medicare and Medicaid. Healthy People 2030 goals are to reduce the number of people who cannot get medical care when needed or their prescriptions filled. Their goals are also to increase the number of people with the primary care physician and who also get evidence-based health care. And then also to increase the number of people who are actually actively involved in decision making when it comes to their health care. When you think about care management, of course, your care management actually deals with the actual population and making sure that they are provided with the service that are needed. And case management actually looks at the individual and it deals with mostly your acute care illnesses such as diabetes, CHF, and making sure that those clients have everything that they need prior to being discharged home. Care management strategies include an array of categories. If you look in your book on page 273 in box 15.1, you'll see under the care management there is utilization management, which basically make sure that the resources are efficiently used and there are not unnecessary tests being ran on a patient or a client. Critical pathways aims at activities used in a timely sequence. Of course, if a client is seeking care, of course, there is a sequence of care that they should actually offer the client, such as if they come in with a stroke. Of course, we're going to treat the patient's stroke and make sure that they have everything that they need. But then we're going to also make sure on transitioning, they're going to actually get physical therapy in order to get them back to as close to normalcy before they had the stroke. Disease management basically manages specific diseases such as asthma, diabetes, and CHF. Demand management seeks to provide clients with the correct information so they can be the ultimate ones to make choices in their health care. Case management gets a little bit more complex when dealing with clients who live in rural areas. And one of the reasons is due to access to healthcare. So typically, the nearest hospital or physician's office may be 30 minutes out of the way. But one of the things that they can actually use is telehealth, which improves access to care. Models that the case manager can use is the traditional care model. With the traditional care model, it was developed for care coordination for chronic diseases or with patients with complex needs who are at risk for a poor outcome prior to being discharged home. So with that, it includes helping them with medication management, transition planning, client and family engagement, education, information transfer, and follow-up care. With agent in place, this basically allows a client to stay in their home, and typically there has to be an assessment that's done in the client's home to determine, okay, is it safe for them? So they may have to repair certain things. They may have to install grab bars, ramps, making sure that the bathroom is safe for the patient. They may also have to provide a caregiver, an in-home caregiver, to provide care to their client. So some of the things that they may do is medication management. They may also help them with meal preparation and also a little housekeeping. So some tools of case management, just like there are 5 rights or 6 or 7, however how many rights is of med administration, there are 6 rights of case management, making sure that it is the right care, the right time, the right provider, the right price and value, and the right outcome. Now, some of the tools that the case management uses are the life care planning tools. So this come in place when a client has a catastrophic event that actually happened to them, such as a car crash and now they're paralyzed, but then they were also the breadwinner. So they basically have to make sure the client has the things that they need and also help them with resources, with financial resources, because since they're the breadwinner, they do need financial help. So case managers also help with that as well. Case managers typically will advocate for the patient. Advocacy is a priority. They also aim to promote clients' autonomy and self-determination. Some of the process as far as advocacy, they're going to give them information without interjecting their own ideas or thoughts. And they're going to allow the client to make their own decisions. They will also support the client, affirm any of the client's values that they may have. They may also have to problem solve. You know, what if the insurance company do not approve from home health? What is the other alternative that we can actually do for the client? There are some legal issues in case management. Liability concerns of case managers exist when the following conditions are met. The provider had a duty to provide reasonable care but didn't. A breach occurred through an act or omission to act, and the act or omission caused injury a client or damage to the client. So case management have a legal duty to the client. Now we're going to move into chapter 16. We're going to talk about disaster management. Disasters can be both man-made and also naturally occurring. If it's naturally occurring, of course, we cannot basically prevent it from happening, but it's very important to make sure that the community is prepared for certain disasters. Things that we can actually prepare for that we know actually occur in our environment or in our region are things such as hurricanes and tornadoes. This chapter basically describes management techniques to be used in the prevention and preparedness, response, and the recovery phases of a disaster. Hurricane Katrina happened in August of 2005, and it was one of the most catastrophic hurricanes in the history of the United States, where there was a death of about 1,800 people, and the deaths occurred in the Superdome, in the residents' homes, in nursing homes, in hospitals as well. With that catastrophic event, there was a lot of exposure to where, people thought that the city was basically forgotten about. On the next slide, I will show a video. And in this video, it focuses on Big Charity. So Big Charity was one of the biggest hospitals in New Orleans, and They provided care to uninsured and also underinsured individuals. With Hurricane Katrina, a lot of people equate that to New Orleans, but it also affected Mississippi as well. So there was also a loss of life in the state of Mississippi as well as the state of Louisiana. Big Charity was built in the latter part of 1800s and it was operating under the Sisters of Charity. Eventually, the Louisiana State University system took over. So about 2 months prior to Hurricane Katrina, the university actually went before legislature asking for money to rebuild a new facility. Well, lo and behold, 2 months later, you had Hurricane Katrina. And typically, their thought process was um, if they were to reopen, they figured that they would never get a new hospital. So the hospital, the LSU system actually decided not to reopen, even though they were ready to receive patients. So in the meantime, individuals had to seek health care in not so ideal locations. Right after Hurricane Katrina, of course, citizens of New Orleans and they pretty much thought the worst was over. And then there was the breach in the levees. When there was a breach in the levees, that's when you had the flooding of New Orleans. So New Orleans, about 80% of New Orleans actually flooded. The individuals in that hospital was actually in the hospital for about 4 or 5 days after the natural disaster had already occurred. They did everything they possibly could do to evacuate their patients, to save their patients, even though they did not have backup generators because the backup generators went out, once the systems got flooded. Now, while they were waiting to be airlifted or rescued, they saw that nearby Tulane had already rescued their patients as well as their employees, but they were left basically stranded with some of their critically ill patients. So, in spite of the destitute that they were actually left in, only two patients, and I hate to say only two patients, but only two patients actually died while waiting to be evacuated. I will now play this video, and again, this video focuses on Big Charity Hospital. It is about a 12-minute video.
The hospital was legendary.
Charity Hospital gave birth to most of the citizens of New Orleans and gave life to many dying people here. If there's something to be called your mother, it was Charity Hospital. That's our mama.
There were plans to build a new hospital pre-Katrina, but there was no money. It was the perfect storm.
We had a hospital full of critically ill patients when the second generator went out. We were plunged into darkness.
Two of them have already died here on this ramp waiting to get out in this very spot.
Two died here because you couldn't get them out.
Two died here because we could not get them out.
I'd never seen anything quite like that.
I might die with a uniform, but nobody abandoned the patients.
The military went into Charity Hospital and they began cleaning it up.
Out of every structure that we've been able to assess, came up with Charity Hospital as being the best opportunity to regain medical infrastructure in New Orleans.
We had the decontamination team. We had the initial cleanup team. Then the 82nd Airborne came. Two whole companies. We had the Navy there. We had myself and my contingent of National Guardsmen.
Members of the active component Army, the USS Iwo Jima Fire Control Team. We had a professional engineer, electrical engineer on site.
There were doctors that I met who were part of the cleanup efforts. So these were residents in the ER and surgery who came back and helped clean up the hospital. You had people in there who really thought, you know what, we're getting our charity hospital back.
They wanted the first, second, and third floor done so they could be there for people who come in and start, get to work. Had nothing to do with pay, had to do with the people, because people needed Charity Hospital.
The only caveat was that the basement should be pumped dry and there needed to be an assessment of what was in the basement.
They brought 2 pumps over. These were 4-inch pumps. And these machines, and the stuff was out of there in a day and a half. We started decontaminating Charity Hospital. And they went through and they scrubbed stuff out. Then they came back with the water trucks and rinsed everything down. And then we pumped it all out again. After the decam left, then the regular guys, the regular Joes, would come in and clean again.
It was ready to go. I mean, we had hundreds of troops in there, and we know how to do this.
So the place was powered, occupiable, according to the U.S. Navy OSHA standards and their testing. It was cleaned. There wasn't any trash to worry about. The basement was pumped completely dry. The sump pumps were operating just fine. We were ready to operate on the day that all that came together.
And when I reported it to the state and said, hey, the hospital's clean, if you want to open it, we can do it right now. And then I was told that there's no plan to reopen it.
The word that we got was that the governor had condemned the hospital, and we hadn't seen anybody come out. We were the only ones at the hospital. Nobody had come in and inspected it while we were standing there, and we were there the whole time. Somebody was there 24 hours a day. My God, you don't even want to come out here and talk to us and find out what we see and what we know needs to happen because we're here now? I ain't got a dog in this fight, people. I'm not from New Orleans. I'm from Los Angeles.
I was given a directive from out of the administrative headquarters office in Baton Rouge, bolt it up and seal it up and not allow anyone into the hospital. Either do this or lose your job.
Word just came down for us to leave the building immediately, to get off of the property.
The LSU system leadership had planned to move to a new facility pre-Katrina. In July 2005, 2 months before Katrina, they had pitched their proposal to the state legislature, who loved the idea and said, yeah, this is great, but we don't have $800 million to build it. And then Katrina hit in August 2005. It was the perfect storm. LSU decided we're going to keep the doors closed at Charity, and FEMA's going to buy our new hospital.
So there was an attempt to clean it up as quickly as we can and so forth. The problem was the whole facility was not in a state that would be approved by the Joint Commission.
Well, I was one of the first officials to ask to see Charity. I was told no at first. I was told it was too dangerous. And I said, well, I still want to see it. And they said, well, we've got to suit you up. You got to wear one of these white space suits and worried about contamination. I said, I'll take my chances. I got down there, I had 2 of my colleagues with me. They probably had 20 folks from LSU. I insisted on seeing every floor. And the building was fine. The basement had flooded, but it had been cleaned out. And it was clear to me at that point that a decision had been made not on the basis of health care, but on the basis of other considerations not to reopen the big Charity.
FEMA said that for $26 million, the building could be reopened. We appealed, came back at $16 million. So the dial went south when we expected it to go way north. And then began the long, drawn-out battle with FEMA to replace Big Charity.
Wow. They are using this tragedy, this disaster, as an opportunity to get something to fulfill an agenda.
Emergency medical doctors who used to work at Charity are now seeing patients in Hall J of the convention center. They are not equipped to see people with major injuries, severe heart attacks and strokes, or pregnancy care. There is a shortage of hospital beds in the entire area.
But the city of New Orleans had to get on with its business of conventions and said, we need you to move.
So 6 months after Katrina, with no place to go, the best we could come up with was renovating the Lord & Taylor department store.
You go up the escalator to lingerie and you realize that's where the dental chairs are and x-ray equipment is. So we called all of our interim facilities the Spirit of Charity.
Now we're talking about 120 patient visits a day, pretty relentless. We're constantly trying to clean it out, and it's adjacent to a food court that was dirty and had not been cleaned. Because of the food and everything that was there, there were far too many rats to deal with. It was incredibly frustrating because we felt we were on a path to not necessarily open the whole hospital, but open a component of the hospital that could deliver health care better than a tent.
Charity couldn't be open as an interim facility because once you opened it as an interim facility, it was an admission that the building wasn't destroyed. Then you lost all rights to ever argue that the replacement value was what was owed.
I understand that there's business and I understand that there's politics, but there's not, it doesn't make any sense to me because it wasn't what was best for the people.
So about 7 months after Katrina, we had our first rally to reopen Charity Hospital. I was on the list of speakers. The LSU leadership made it clear that I was not to speak at that rally or my contract would be in jeopardy. It goes against what university principles are all about. Not just free speech, but to invoke new ideas, because that's what we try to do with our students, and that's how you build leaders. And here they were squashing that. So I resigned. You know, there's some things in life that are important enough that you have to take a stand. The Foundation for Historical Louisiana was able to commission one of the leading architectural firms to see if Charity Hospital could be restored and reopened as a state-of-the-art hospital.
The 7th largest architectural firm in the world designed a beautiful concept plan that showed that we could get everything they wanted in perfectly, and every room was a private room. We would gut it and build a state-of-the-art hospital inside, using the buildings around Charity Hospital as the ancillary buildings. You'd save 34% in the construction costs alone. We could finish in 3 years of construction time. That would have been 3 to 4 years ahead of what the schedule is right now. When we released the study, they said we were wrong and that we can't possibly be right.
I mean, this place, all the doors, this place is locked up like Fort Knox right now. Something's being hid inside this hospital. No doubt about it. A building that's functional as a hospital.
As our services expanded, we would go back to get more and more supplies. Each and every time we went back to Charity, it looked like a new hurricane had come through the building. I can only guesstimate what happened and the reasons that it happened, and I don't think I'll go into that.
Trash throughout the place. That happened 3 or 4 days after we were out of there. Equipment being upside down, turned over, equipment not where we left it.
It was all an intentional effort. A decision was made somewhere higher up to scuttle Charity in behalf of a new hospital. Scuttling is a maritime term when they take a ship out and sink it intentionally, and so I think it applies well in this case. I've never begrudged the desire to have a new hospital, but in the fashion they achieve their goal, it's very immoral and unethical and probably criminal.
Were you ever told to not talk about going back into charity?
I can't talk about that. I can't do that. Trying to see how I can give you an answer to that without saying that. There's nothing I'm going to be able to say that will paint them in anything other than an awful light, and that'll come back to me. So I'd prefer not to do that.
I know of several people who were told not to talk about Charity Hospital. I was personally standing next to one of the doctors, and point blank he was told, and I was standing less than 4 or 5 feet away from him, if he knew what was good for him, he would let it drop. And the gentleman walked away.
The word was put out that if you buck their efforts, that you would no longer be needed.
The guy goes, if any more of you all get on camera or try to set up health care down here, he said, I'll make sure you never work in this state again.
Charity Hospital in New Orleans served as one of the healthcare providers in providing care to the vulnerable population. Charity Hospital was a 2,680-bed hospital with emergency services, labor delivery, and mental health services provided to the patients. They received about 200,000 ER visits annually and provided care to the uninsured as well as the underinsured. The challenges with Charity was that they were underfunded. There were no private rooms nor bathrooms. Typically, they would have 10 patients in one room to one bathroom. It was poorly maintained, and one of the reasons out there of why it was poorly maintained because they didn't want to pour any additional funds into the hospital because they wanted to build a new one. There was a feasibility study to see about opening up Big Charity, and it would have cost about $484 million to remodel it in 3 years. Now, the Louisiana State University, which controlled the Charity Hospital at that particular time, actually wanted a new facility. They wanted it to be called the University Medical Center of New Orleans. So some of the opportunities there was that they will have a 446-bed facility that offers emergency services and mental health. It will be more newer and up to date with modern facilities. There will be private rooms and bathrooms, and they will also provide care to the uninsured as well as the insured patients. So they wanted to provide care to those who had private insurance as well. Now, the cost of a new facility will be $1.2 billion to build in 5 years. Now, even though Big Charity was old and in need of repairs, the question is, was the Louisiana State University system justified in not reopening that hospital in order to get a newer, more modern, up-to-date hospital? So think about that. You know, there's a feasibility study that says, hey, we can reopen in 3 years, but no, they wanted to have a new facility in which they will open up in 5 years. So in the meantime, where would those patients actually go and seek care? When you think about disasters, it can be natural or human-made, and it's an incident that causes disruption, destruction, and/or devastation requiring external assistance. It can range in size and also expensive as well, depending upon the destruction of that natural disaster. Sometimes there's little to no warning when a natural disaster actually occur, such as earthquakes and bioterrorism. They often have more casualties because of the lack of time to prepare or to obtain treatment. In the developing countries, they are basically disproportionately burdened when there is a disaster that actually occur because they don't have the funding and the infrastructure to rebuild. And your vulnerable population is excessively more affected and less able to rebound because they don't have the financial support or financials to even rebuild their homes or their property or businesses. Now, typically, when disasters occur, um, there's usually more catastrophic or loss of lives in overcrowded, urbanized areas, due to the fact that sometimes in a disaster, as in Hurricane Katrina, there was a lot of civil unrest and rioting that was actually going on. But at that time, those people were desperate. But on the video, you actually see some of them stealing shoes and TVs, and I'm like, well, that's not a necessity, but I can see if they were stealing formulas and diapers and, canned goods and things of that nature, because basically they were left, at the Superdome or in their homes or in the hospitals or whatever, like about 4 or 5 days after the natural disaster have actually occurred. So some of them were in survival mode, and some of them was basically, rioting the area and stealing things that was really unnecessary. Now, worldwide, the number of disasters have continued to grow, but the number of lives lost have decreased due to better disaster forecasting and early warning systems. So currently, we have warning systems in place if there's a tornado in the area, or if there's a hurricane out there that's threatening the Gulf, things of that nature. We receive those warnings in order to have time to prepare. Although natural disasters cannot be prevented, much can be done to prevent accidents and deaths and destruction after the impact. So typically when natural disasters occur, of course, you have different national departments actually come into play. Of course, you have the U.S. Department of Homeland Security, you have the National Preparedness Guidelines, you have the National Response Framework. CDC may get involved due to what type of natural disaster it is, and also FEMA. When you look at the disaster management cycle, there are 4 categories. There's prevention and preparedness, which actually occur before disaster, and then there's response and recovery. Response and recovery actually takes place after natural disaster has occurred. Prevention and mitigation seeks out, there are actually things that you put in place in order to minimize the loss of lives and property. So certain things you may have to put out there is like awareness and education. You may have to do disaster drills, things of that nature. You may also have to assess the environment for any health related hazards. You may have to assess that particular area to improve things like the ditches. So you may have to clean out the ditches. You may improve on building codes. So you may require new homes and new buildings have, you know, windows that can sustain about 150 mile per hour wind or what have you. So you seek out to do things in order to prevent or in order to decrease the likelihood of destruction when a natural disaster actually occurs. You may also do things like boarding up windows, boarding up doors. You may also have to put an evacuation plan in place, just in case a hurricane directly hits that particular area. With preparedness, personal preparedness, you may want to teach your client, to develop a checklist, things that they may need. You may also get them to create an emergency supply list. So in that emergency supply list, you actually have an example of that on page 292. And typically what you would educate your client is to make sure that they have non-perishable items such as canned goods, things that doesn't need to be heated up. They may need, medications, and typically for about 3 days. They may need a first aid kit, flashlights, batteries, copies of important documents put in waterproof containers. They may have to make a plan, talk about the family plan. Okay, if a disaster happened, okay, where are we going to meet up? Do we meet up at a particular place? Typically, you can prepare for certain natural disasters, such as, hurricanes. Floods, not so much, because typically there's usually like flash floods. Tornadoes, typically, if there's a warning that a tornado is in your area, you may only have a few seconds to a few minutes to actually get to safety. With professional preparedness, you have the American Red Cross where they do their training, and other community departments that actually train on disaster preparedness. You may also have community preparedness such as FEMA, the National Health Security Strategy. You know, there may also be disaster mass casualty exercises that also actually occur in the community. Now, after a natural disaster and when it's safe to do so, you will have the level 1 response that may occur from local fire departments, law enforcement, or other public health agencies. Emergency services will also be deployed to help, rescue others who actually need to be rescued. Now, if it gets to the point where the response mission is too much for that particular local department to handle, they may reach out to the mayor, the governor, and the governor will reach out to the president to declare their area as a natural disaster area. When that happens, they will dispatch the National Response Framework. And basically, what they do, they help with transportation, communication, public works, engineering, mass care to those who actually need it, emergency assistance. They help with housing, medical care, supply, equipment, and supplies. The National Incident Management System manages emergencies from preparedness to recovery, regardless of the cause, the size, the location, and the complexity. And there are times there may be bioterrorism that actually occurs, and there's a response to that as well. And typically, you wouldn't know that that's actually happening until there are individuals who are coming to the ER to seek treatment. When the outbreak occurred, it must be detected. The cause must be determined in order to implement control measures. Now, typically, when there's a bioterrorism, of course, there is this strategic national stockpile. And basically, what that is basically warehouses that are stationed throughout the nation that store supplies and medications like antibiotics, antivirals, antitoxins, vaccines, and certain type of chemical antidotes. During or after a natural disaster, sometimes there may be psychological stress on disaster workers. They're constantly helping out, and the helping out can be rewarding but challenging at the same time, and stressful. Stressful due to constant change, stress of getting everyone the help they need. They may have to wait in lines to get to work. Their sleeping quarters may be less than ideal. So if you work in a hospital, you may have to stay over at a hospital in an area with other employees. Typically, those who are actually helping out in disaster management, they may also neglect, self-care. Now, even though they're helping other individuals, they're also concerned about their own family members, which also causes more stress on them. In the recovery phase, typically in the recovery phase, they are working on to returning their environment or the community back to a sense of normalcy. So typically, your recovery is going to include, organizations like churches, things like the Red Cross, to try to get the community back to where they were prior to the natural disaster that actually occurred. Your recovery phase is usually the longest phase. And there are certain roles that the nurses can do in disaster preparedness, such as help initiate and update agencies' disasters plan, provide educational programs and materials regarding disasters specific to an area, organize disaster drills, provide an updated record of vulnerable populations within that community, especially those who are on things like oxygen or hospice care or something to that effect. And they may also review individual strategies to see if there needs to be additional updates to that. The role of the nurse in disaster response depends on nurses' experience, their professional role in a community disaster plan, specialty training, and also special interests. They're also there to advocate, to do an assessment, to understand what resources are available for the community. They also may aid in surveillance, triaging patients that actually come in, provide first aid. They may also be instrumental in doing a rapid needs assessment and also to manage shelters that have been set up. Now, in a natural disaster or in a mass casualty event, so mass casualty is basically when you have a whole lot of people that are hurt at the same time. And typically, nurses or those who are actually helping in the disaster area have to categorize the victims. So they categorize them in 4 categories. So red, typically they're gonna seek care, right? Emergency care. Those are those who have airway issues, severe burns, signs of shock, open chest or abdominal wounds. And then you have your yellow. Your yellows are those who have burns with no airway problems, major or multiple bone or joint injuries, back injuries, with or without spinal cord injuries. Excuse me. Your green are those who actually have like your minor fractures, your soft tissue injuries, and then your black or those who ultimately is basically obviously death is getting ready to occur. So, and typically you have to put these in categories because you're going to have more victims than you have personnel to provide care for them. So when you are categorizing a victim as black, typically, they're probably going to die, and so you're going to put your focus on individuals who are more likely going to make it. So we're going to try to put these victims in categories. So you arrive to a scene of a 10-car crash. There is a 40-year-old male victim with severe head trauma and agonal breathing. There's a 3-year-old child with laceration to the left side, a 75-year-old female with a punctured chest wound, and a 22-year-old female with a left knee abrasion. How would you categorize these particular victims? How would you categorize the 40-year-old with a severe head trauma and agonal breathing? How would you clarify or categorize the 3-year-old child with a laceration to the left side? How would you categorize a 75-year-old female with a punctured chest wound? And how would you categorize a 22-year-old female with a left knee abrasion? Now, if I'm looking at the 40-year-old severe head trauma and the agonal breathing, I would categorize that as black. The child with the laceration to the left side, I would categorize that as yellow. The 75-year-old female with a punctured chest wound, I would categorize that as red. And the 22-year-old female with the left knee abrasion, I would categorize that as green. How did you do? Now, additional role of nurses in disaster recovery will include teaching proper hand hygiene and making sure the immunization records are current. Make referrals to mental health professionals because if it depends upon how drastic that disaster was, such as Hurricane Katrina, you still have victims who are still dealing with the impact of that particular disaster. You also want to teach about being alert for environmental hazards. So if there was a hurricane, you have to teach about safety. Typically, your injuries occur after a hurricane. So things like they may be clearing the roadway. So they may be using a chainsaw. And they have to be careful when cutting up trees to make sure it's not on a power line. So you have to teach about potential execution. You also have to teach about things like when they are using a generator. You have to teach them not to use a generator in the home, making sure that the generator is on the outside and it has to be a certain amount of feet away from the home. It cannot be next to a window. Make sure the window is not open. You want to close the window due to the risk for carbon monoxide poisoning. So you want to teach about not only what to do before disaster, but also how to stay safe after disaster has actually also occurred. You want to teach them about assessing dangers of live and dead animals and also being careful when entering homes. Some homes are not safe to even enter. And then nurses may also be involved in case finding and referral. Now, back on educating about environmental hazards, you also have to look at the fact that the infrastructure is going to be down. So traffic lights may not be working. So you have to teach about, making sure that they're stopping at four-way stops or intersections to reduce the risk of car accidents. You may also want to teach about overexertion. So typically people want to try to get back in their homes, but you may have to teach about making sure they're taking their time and taking rest breaks, drinking plenty of water, things of that nature. People react to the same natural disaster in different ways, depending upon their age, their culture, their background, their health status, their social support and structure, and also their general ability to adapt to crisis. So when you look at the stress reactions in the community, so there are 4 stress reactions: heroic, honeymoon, disillusionment, and reconstruction. So heroic is where there is an overwhelming support of people coming in to help other people, um, such as first responders. They are willing to work and sacrifice their own needs. They typically experience a lack of sleep, but they refuse to rest because they have a job to do in helping others. And then there's the honeymoon phase where survivors are happy that they're alive, and that they've been spared, and they want to try to share those experiences. And then there's the disillusionment phase, where you begin to notice that additional help may not be immediately available. There's a sense of despair and exhaustion. The community begins to realize that there's a return back to normalcy. However, the return may not be in the immediate future. And then there is reconstruction. And typically, your recovery, your reconstruction actually takes the longest. So typically, your homes, your schools, and your churches begin to rebuild and establish the community. And the goal is to return back to a state of normalcy. And just to add, in the recovery phase, typically they want to try to get the infrastructure back up, such as emergency services back up, cell phone tower signals back up, emergency power. Those things are like on the priority list to get those things up and running. Then they focus on things like, rebuilding houses and things of that nature. Typically, nurses make ideal shelter managers and team members because they're comfortable with dealing with, the population. They're also comfortable in health promotion, disease prevention. Working in shelters, they can provide assessment and referrals. They can also meet the healthcare needs of those who are actually in the shelter, such as prescriptions, glasses, medications, first aid, and appropriate diet adjustment. They also can keep good client records, ensure emergency communication, and also provide a safe environment. So the future of disaster management includes continuous to plan and train in all hazardous environments, regardless of the specialty practice. Also, natural disasters will retain the element of unpredictability, so it's always unpredictable, and that's why it's very important to stay current on disaster training. All right, chapter 18, we will discuss program management. I will tell you some slides I will go ahead on and kind of skip over, and I'll just kind of focus on the things that you guys really need to know. So this chapter is going to explain more about how nurses act instead of react by planning programs that can be evaluated for their effectiveness. So when you think about program management, you're thinking about assessing, planning, implementing, and also evaluating. The same thing as the nursing process. And basically, you're looking to see, okay, is this program is a need? Is it meeting the needs of the people? Is it meeting its goals and its objectives? We've already discussed what program management consists of. We will move into formative and summative evaluation. So your formative basically assesses if the objectives are met and is usually ongoing. So during the program, you're actually doing your evaluation. And then there is summative, where the overall evaluation at the completion of the program, where you look at the overall evaluation of the program. So typically after the program has ended, maybe within a year, maybe within 5 years, you're looking to see, okay, were the objectives met? Similar to the semester. So throughout the semester, you may have quizzes and tests and presentation. So that's more like your formative. And then when you get into your final exam, that's more like summative. Okay, at the end of the semester, let's do an evaluation to see, okay, did you learn anything in the semester? Kind of like the same concept. Now, when you look at program and project, so your program is typically something that is ongoing. It's an ongoing activity that becomes part of a health service of a community or organization. And then your project is more short term. So things like your community event or your health fair. Now, planning is basically selecting and carrying out a series of activities designed to achieve improvements, and evaluation is used to determine if a service is needed and does it help out the community. Now, there are benefits of program planning, so such as benefits clients, nurses, and employing agencies and the community. It focuses attention on what the organization and health provider or attempts to do for its clients. It assists in identifying the resources and activities that are needed. It also helps with decision making and better control of what's actually happened with the program. So the program planning process. So when you're planning a program, you want to identify what the problem is, as well as what the need is for the community. You also want to look to identify any available resources. You want to review any literature that's out there, maybe something already available that is evidence-based and have been proven to work. You also want to evaluate the possible problem solutions. So you may want to look into a decision tree and then choose the best solution. So again, the program planning process and the nursing process is pretty much the same. And here are some of the steps. So with the planning process, you want to create a successful program, but it relies on careful assessment of the population or the community to identify the needs. That's the assessment piece. You want to take into account all the stakeholders, and they should be involved in the formulation of the goals and outcome. You want to implement appropriate interventions, and it should be based upon those goals that you've already formulated. And then lastly, of course, you do your evaluation, whether it's formative or summative. And again, formative is when you're doing your evaluation as a program go on, and then your summative is when you do the evaluation at the end of the program. There are actually three program planning models for public health, and that's actually found on page 323 in box 18.3. So it shows three models. So there's the patch model, that's planning approach to community health, and it considers health education a process that helps people to be more in control of their health. It views the client as essential to the planning. And then you have APEX PH, which is the assessment protocol for excellence in public health. And this particular model actually addresses the three core competencies of public health. And then you have the MAP, and that is mobilizing for action through planning and partnership. And this is more of a newer model, and basically it establishes priorities in public health issues and identify resources to address those particular issues. Now, when you're doing a program evaluation, you're looking to see if the program is meeting its purpose, its objectives, its goals. It should answer, are the needs for which the program was designed being met, and are the problems it was designed to solve being solved? Is it actually working? Now, with program evaluation, you do have to formulate objectives. So, and what falls underneath that is things like with the mission, you look at your mission. So, your mission statement should be what your values are. And then you look at your goals. So, your overall aim is maybe about 1 to 2 goals, and it should be guided by your mission. Then you look into your objectives. You have to pretty much use specific measurement outcomes to meet that particular goal. So it should be measurable, time bound, realistic, and attainable. And then, of course, you have your action steps. That's your interventions. And then how are you going to evaluate that plan? What methods are you going to use? Are you going to use a survey? Are you going to use different health records? Or are you going to utilize your own observation? And here's basically I guess, more specific to your formulation of your objectives. once you come up with your objectives, of course, you have to look at it as being something that is measurable. Okay, so when you're looking at your objectives or formulating the objective, there should be some type of action-oriented verb to specify the behavior. You know, a statement of a single purpose. You should also have in there a single result and also a time frame for achieving the expected results. So here's an example of an objective. So this is something dealing with immunization in schools. So here's an objective that's been formulated to decrease the incidence of early childhood disease in Center City by providing immunization clinics in all schools between August and December. So it gives an action verb. It also gives a single purpose, an outcome, and also a time frame in which to meet that particular objective. All right, there are certain sources you can actually look at to evaluate the program. Most often, the client is actually being used. So you may formulate some type of client satisfaction survey. You may also observe, you know, is this program actually working? You may want to use your own observations. You may want to look into any type of program records. So, for example, let's say, for instance, the goal was to reduce incidences of low birth weight in babies through prenatal care. So you will review those records to see the number of mothers who receive prenatal care and the number of low birth weight babies born to them. You may also look at epidemiologic data. You may look at the community indexes that may include morbidity or mortality rates in relation to whatever it is that you're trying to reduce. So the aspects of program evaluation, one of the aspects is relevance. Is there a need for the program? Adequacy. Is the program large enough to make a positive difference? Progress. You may want to track the program activities to seek out, is it actually meeting the program's objectives? And with that, you can use formative or summative evaluation. Efficiency. Is there a relationship between the program outcomes and the resources spent? How do the costs of the program compare with those of a similar program to meet the same goal? Effectiveness. And this is basically the ability of the program to meet its objectives. And are the clients actually satisfied with the program outcome? And impact. Have there been a change in the population health? For example, if you're doing a program about reducing obesity, you know, has there been a reduction in obesity? Have there been a reduction in teenage pregnancy? What is the impact? Did it promote any change? And sustainability. Are there enough resources, usually money, available to continue the program? All right, we will move into chapter 19 where we'll discuss healthcare improvement in the community. Of course, when you're dealing with quality improvements, there are actually 6 areas of performance. And those areas are consistently providing appropriate and effective care, reduce unjustified geographic variation in care, eliminating avoidable mistakes, lowering access barriers, improving responsiveness to clients, eliminating racial, ethnic, gender, or socioeconomic and other disparities and inequalities in access and treatment. So those are 6 of the areas of quality improvement. Now, the healthcare delivery system is the largest employing industry in the United States. And of course, society is demanding increased efficiency and effectiveness from the system. So a lot of the organizations are actually using quality improvement projects in order to improve the quality of care they actually provide to their clients. So when you're thinking about definition and goals to quality, typically your quality, you want to just make sure that you're providing safe care to your client, okay? And then the goals are to continuously improve the timeliness, effectiveness, safety, and responsiveness of programs, and also to optimize internal resources in order to improve the health of the community. Now, some of the things that an organization may want to try and improve on, things like client death, especially things specifically, especially if it's unexpected, such as like PEs, pulmonary embolisms. They also may want to look at, client injury, client safety. They may want to look at the supply chain. They may want to look at any program that they feel like they can actually improve. There are several models that can actually be used in the improvement process. One of them is the Donabedian's structure process outcome model, and I'm not gonna focus in on this one. So there are several other ones besides this one, and I'm gonna focus on the Plan, Do, Study, Act model. You have the tracer model, which basically looks at particular illnesses such as CHF patients or diabetic patients. So, and basically what this does is evaluate the outcome of a specific group or population and evaluate the care in which a institution actually provides. They will look at the shared healthcare issues, similar interventions, similar needs, clients or patients from the same community, same lifestyle, and also be at the same disease stage. So they look at a particular population and they determine, okay, with this particular population, is it something that we can actually put into play in order to improve their health outcome. With your Sentinel method, this is pretty much based on epidemiology. So they may look at, your HIV cases, your encephalitis cases, things of that nature. You may not see your Sentinel method a whole lot unless you work in public health or community health nursing. So your Plan, Do, Check, Act is probably one of the methods, quality improvement methods that you'll probably see most often. So typically they will get a team together. And let's say, for instance, they're trying to reduce falls in an organization. So they'll get a team together that are actually frontline with the patient. So they may get the nurses, they may get a physician, they may get a PCA, physical therapy, occupational therapy. So they'll assemble a team together and they'll come up with a statement. Okay. They'll also come up with the problem. What are the issues? Why are our patients falling? They will look into the problem and then they will formulate an action plan. They will put that action plan into play. And then as the action plan is ongoing, those interventions are ongoing, they'll be evaluating, okay, is this new action plan actually reducing falls in our patients? If it is, they will continue on with that plan. If it's not, they will go back to the drawing board and figure, okay, why is this plan not working? And then they'll formulate a new action plan and then evaluate that. So it's a constant cycle to the point where, okay, they're gonna keep going back to the drawing board to figure out, okay, what's going on, why these interventions not working. And once they figure out, okay, the right implementation or the right interventions, then that intervention may become a permanent part of that particular process in reducing the patient's risk for falling. Even though you may not be directly involved in quality improvement projects or programs, you may be indirectly a part of it, such as your documentation. So they may look at documentation. They may look and see how often are nurses document on the risk for patient falls or how accurately they are documented, because they may pull those documentation records to see, okay, is the documentation is an issue, or the nurses not following through with the implementation. So you may be indirectly involved in certain quality improvement projects. So make sure that your documentation is accurate, for it is a legal document that actually can be, you know, subpoena for, you know, a court case or what have you. All right, this conclude the lecture for chapters 15, 16. Chapter 17, we've already pretty much discussed that. Chapter 18 and also chapters 19.